Good morning, everyone. I would like to welcome to the Master Clinician series, and today we have a great demonstration here of a regenerative endodontic procedure. We'd like first to thank some of the people who made and the companies who made this possible. We'd like to thank Jay Morita. We have a VeraView Epox 3D machine that's sitting right there, and it's going to be used pre-operatively. And if you have any questions about this, they will be glad to answer any questions after the presentation. We'd like to also thank Harry Shine for the operatory, for setting all this up. Karamark and Kodak for the digital sensor and the digital radiography system that we're going to use today. Global for the microscope. ASI for the integrated cart that we have here on the left. Biomed RX, also known as Biomatrix, that is providing the venopuncture kit and the PRP isolation system that you're going to see being demonstrated today. Dr. Todd Geisler and Dr. Fabrizio Teixeira will be the doctors who will be performing this procedure today. Dr. Geisler would like to disclose that he has financial interest in the Biomat company. He's one of the founders of the company. So this is just a disclaimer. And I would like now to give you a brief introduction. There is natural discomfort with anything new. Any new treatment modality usually raises some kind of skepticism and some kind of, let's say, hesitation. Consequently, regenerative endodontic therapies have not been fully incorporated into every endodontic practice. It's been limited largely to academic institutions and to few practitioners who are already adapting this procedure. Todd and Fabrizio have put a novel learning experience for you today. And once become comfortable with these new techniques, you will find them easy to perform, hopefully, and your confidence will grow in being able to offer and deliver this new treatment modality. Your newfound expertise will serve as great taking point with your referring docs, and you set your practice apart from those other practices who are not incorporating this type of procedure. In order to save time, I will give a brief bio of these two gentlemen. Fabrizio is a colleague of mine at University of Texas Health Science Center at San Antonio. He's the director of the postdoctoral program in endodontics, the residency in endodontics in San Antonio. He has a DDS from Brazil, from Unicamp, and has his PhD also from there in endodontics, and his residency training at University of Texas Health Science Center at San Antonio. Todd has a practice that is limited to endodontics in Richfield, Minnesota. He graduated from UT Health Science Center at San Antonio in 2008 and worked with mentors such as myself, Bill Schindler, Scott Schwartz, Michael Henry, and of course, Ken Hargreaves. For the past 2 years, he has performed a hands-on workshop on autologous fibrin matrices in regenerative endodontic procedures with both Donna Matschek and Alan Law. By way of full disclosure, Todd wanted me to mention that he does have financial interest in some of the products that will be used today. So without further ado, I'd like to call Todd and Fabrizio Teixeira to come here and start our demonstration. Thank you very much.
Thank you.
Also, if there are any questions during the procedure, we would encourage you to write them down so that we're going to have a little break, a Q&A type of session after the presentation is done. But if there is a question that it's imperative to be answered during the treatment, you can raise your hand, I'll come to you, and we're going to try to address that as we go. Okay?
Yeah, great. I think I'm good here. Check, 1, 2. Can I get the screens on right up? Oh, there we go. This is great. This is phenomenal. I've never lectured in 365 degrees, so you don't, or 360. I've never done this, so you don't know exactly who to focus on. But I want you all to do me a favor. If you would, play along with me. Everyone go ahead and cross their, you're already doing it. Cross your hands. Everyone cross their arms. Feels pretty good. Feels pretty comfortable. Yeah. Now do me a favor, if you can, put the other arm on top. How does that feel? Uncomfortable? A little weird? Why do you think it feels so uncomfortable? Not used to doing it that way? Bit of a change? Well, if you're uncomfortable with regenerative endodontic procedures, you've come to the right session. So truly, if I can do this procedure, anybody can do this procedure. These are easy procedures. I hear a lot of people are kind of scared to do it. In fact, they're less technique sensitive than your average root canal. So really, this is what you signed up for. I have a wonderful patient that I'm going to introduce you to in just a few minutes, and she's going to really help everyone learn here. So we really appreciate her flying all the way from Minnesota to help us. We're working on 2 teeth, 8 and 9. One we're going to do blood clot scaffold, so the traditional Banks and Trope type procedure. And then the other one, we're going to do autologous fibrin matrices. Autologous fibrin matrices I use as an umbrella term to include a lot of different plasma concentrates, including PRP and PRF, PRGF, these different plasma concentrates. But we'll lump them all together under AFM, autologous fibrin matrices. So before we get started with this, I want to talk about the 3 R's of regenerative endodontics. And this is kind of the mantra that I'm going through and as I think about regenerative endodontics. So rethink, resolve, regenerate. And so in the next 80 minutes, I'm hoping that you will change the way that you think about treating these cases, and that you walk out those doors with the confidence, with newfound confidence, to do these procedures in your practice, and that you'll discover that with the right armamentarium, you'll find these procedures very easy, and you can regenerate the pulp. Now, we all know the controversy about regeneration. Is it truly regeneration? Is it revascularization, revitalization, or regeneration? But we'll just kind of lump everything together, and we're calling this regenerative endodontic procedures, REPs. So who am I? I'm not presenting here because I'm a brilliant mind. I'm not that important, but what I can offer is to communicate on a clinical level. I'm here to give you the nuts and bolts of the procedure. I'm in the trenches every day, just like a lot of you, and the only thing that matters to me, is that you take something back to your practice that you can use. Okay? I have worked with brilliant minds like Aníbal here and Fabricio and folks like Michael Henry, Ken Hargreaves. But just as important, I've worked with great clinical mentors, folks like Carl Kaiser, Rick Schwartz, Glenn Walters, Scott Schwartz, Bill Schindler. These folks really have influenced the way I practice. So my goal is to take it from theory to practice, from academia to the clinical realm. So let's get a show of hands, just real quick. How many of you are doing regenerative endodontic procedures right now? Have done a few. About 40%, 30%? Good. So of those that haven't raised their hand, what are the barriers? What's stopping you? Too much of a change? Not comfortable with the procedure? Right. So I'm going to take the next 10 minutes and just go through these 3 R's, and then we'll get right to the procedure, okay? And then we'll have some time for Q&A at the end. So the first thing that we need to do is rethink. Rethink. We need to have a beginner's mind. We need to be open up to the possibilities here. And I had a chance to see Alan Law speak at the fall conference. It's a really amazing speech. But one thing he said and talked about was kind of opened my mind, and that's this idea of cognitive dissonance. Now, we all know cognitive dissonance from Seltzer and Bender and that, but this is a new application of this. And this is, we say that this gutta-percha-filled root here, it's usually better than this, right? We're endodontists. But why then are we often unwilling to say that a living pulp is not necessarily better than a gutta-percha-filled root? So we need to rethink. I saw another lecture in Washington, D.C. by a really fantastic lecture by Stéphane Simon, And he showed this picture here. I don't know if y'all can see that, y'all. Back in Texas, speaking like a Texan. He has a tooth here that he opened up and accessed. The mesial canals had necrotic tissue in them. He obturated the mesial and did a MTA pulpotomy, cervical pulpotomy on the distal. Now, how many would do this? Not me. Not me before I saw that. So, but it just makes us think. Makes us think. Are we guardians of the pulp? Or are we snatchers of the pulp? Are we guardians or snatchers? The second R is resolve. We know these things work, right? From Owaya's case study in 2001 to Banks and Trope in 2004, all the way to torbinajad and Turbin in February of this year. This is an amazing case. We'll talk about it a little bit later. So the question, as Ken Hargraves likes to say, is the question is not, do these procedures work? We know they work. But the question is, how are we going to do this predictably in our patients and get predictable outcomes? The third R is regenerate. Regenerate. So if we even want to truly have a chance at regenerating, we need to have a strategy on how we go about it. We need to have all three elements of tissue engineering. And that's stem cells, growth factors, and scaffold. So that's the holy grail of tissue engineering. We've got to put these three things together, and we have to be thinking about this as we're doing these procedures. Now, Blaine Thibodeau and Fabricio had a great study, dog study, out of UNC, and just a quick review here. They looked at dog teeth, 60 immature teeth, and they found that what was the most important? Blood clot. Blood clot was the most important. It was an increase. They saw an increase in the percentage of roots with new tissue in the canal and percentage of roots that had newly developed hard tissue on the canal walls. So very important. And it was when I saw Blaine present his paper at the AE that I thought, you know, maybe there's a chance that we could do something simple to maybe have something even better than blood clot. And Da Vinci said simplicity is the ultimate in sophistication. And so what if we took the things out of the blood clot that we probably don't need? Red blood cells, they're going to die, right? White blood cells, they're going to die. They're going to release all their enzymes and break down the scaffold. So what if we could take out those unwanted cells and have a biomimetic scaffold with increased growth factors? So simple, elegant, and what's the evidence for platelet-rich plasma, or AFM? Well, let me talk about torbinajad's case. This was an 11-year-old boy who had had his tooth accidentally extracted. Not sure how that happened, but came to the clinic, tender to the bite, negative to cold, negative to EPT, positive to percussion and palpation. Excuse me. They placed triple antibiotic mix. Patient came back 22 days later. The tooth was no longer sensitive. What they did was they anesthetized with 2% lidocaine, took blood from the patient, used this Harvest Smart Prep machine to prepare PRP, and importantly, they did not stimulate bleeding. Did not stimulate bleeding. They injected the PRP in there, restored it with MTA, and 5.5 months later, these were the results that they saw. And at this time, it's positive to cold, positive to EPT, full resolution of the periapical radiolucency, root development, and apical closure. Look at this. These results are really quite amazing, in my mind. 5.5 months versus many times 18 to 30 months on the cases, on some of these other cases. So what's important about PRP? PRP contains growth factors such as VEGF, angiogenic factor. It stimulates collagen production, recruits cells to the site. All these things that we think that are probably beneficial. So no longer are we looking at the scaffold as just a simple lattice for cells to grow up, but it's a lattice with growth factors. It's a part of tissue engineering. And then if you have stem cells that are at the apex of the root already, and you put these things together, we're thinking along the lines of tissue engineering. So today you're going to hear things and you're going to see it, but if you really want to do it, you need to, if you really want to understand it, you need to do it. And here's my shameless plug because I have a few openings in my workshop tomorrow. So if any of you all would like to come, I'd love to have you sign up. So I have, you know, in talking to Fabricio, I thought that I probably wouldn't do this procedure today. I'd probably have some volunteer because it's so easy. So easy to do this, right? Anyone volunteer? No. No, I'm gonna do it, but that's how easy I think it is. It's very, very easy, very simple. Don't worry if two, we're okay. So here's the nuts and bolts of it. I'm gonna introduce you to my patient, Iftu Ali. We're gonna go ahead and get a scan. That's her. Can we give her a round of applause, please? I'll tell you a little bit about Iftu. She's 21. And at the age of 8 or 9, she had trauma to her anterior teeth. And she presented to me in September of last year. It was fortunately right after Cindy Rauschenberger asked me to do this. And I was hesitating, and then Iftu walked into my office. I thought, perfect case, perfect case. So fortunately, Iftu agreed. So this was her September. And what I did do, I didn't want to leave her like that, so we did initiate appointment number 1. So when we do appointment number 1 today, we're going to be mocking it a little bit. I'm going to take out what's in there, and we're going to put in the double antibiotic paste for her. So I think we should get right to it. As soon as we're done with the scan, we want to get right to it. And these are my lovely assistants. We have a few seconds. Yeah, go ahead, Kathy. Right, so, and we could talk about that a little bit more, but the triple antibiotic paste I just find really, really stains the teeth. The minocycline, you know, obviously there's other ways to prevent staining. The Reynolds paper, where we've got a projector and flowable composite, or just bonding agents in the coronal chamber. But in areas where it's really, aesthetics are crucial, I've moved to the double antibiotic paste, and we've had good results. I know that's anecdotal, but we've had good results with that. These are my lovely assistants here. Any other questions, as long as we're waiting? Yeah.
The first time you saw her, you did the access, I'm assuming, and cleaned out the necrotic pulp.
That's why I wore this really stretchable stuff so I could run around.
So if I understand correctly, the first time you saw in September, when you made the access, cleaned out the necrotic pulp, and put the double antibiotic paste, did you go back in and flush it out, or it's been there since September?
So I changed it one time.
Okay.
Yep. And so we flushed it out and changed it.
Okay.
And now there is antibiotic paste in there. Yep.
Your range of time for that change for the antibiotic? Any particular change for the frame of time for the change of the antibiotic?
Typically, I'm doing it when I'm not waiting to present at a Master Clinician series is about 3 weeks, about 3-4 weeks. And that seems to be what the protocol is at UT as well. Yes, ma'am.
Questions?
You changed the antibiotic twice. When do you know that it's now is enough? I'm gonna like finish the case. I mean, do you have to change it another time, or when? How do you decide?
Right. Well, certainly if the sinus tracts go away, and that's what happened here. The sinus tracts have gone, and so I'm ready to fill. And most of the cases that I've done have had sinus tracts, so that's an easy indication. I'd imagine that if I open the tooth and I have purulence, then we need to do another round.
If it's another one. If it's a necrotic tooth, do you like use filing or anything in the first
minimal
visit,
instrumentation, almost no instrumentation really. And if you look back at the papers, the Banks and Trope and things, we're not doing instrumentation here. This may not be true going forward, but we're not doing instrumentation now.
Any other questions? Anybody? Okay.
What do you use to put the antibiotic paste in the tooth? You use like a lentulo or one of the P files or something like
Great,
that?
I'll show you how I do it. I know Anibal uses a centric syringe. I'll show you how I just use kind of a regular syringe. One of the important things with your triple antibiotic paste, when you get it from the pharmacy, and I'll show you here too, I get pure drug. I don't get drug with filler. We used to do at the workshop where you crush the pills and you mix it all together. That has a lot of lactose and filler in there. We don't want that in there. So we do 1-to-1-to-1 of pure drug from your compounding pharmacy. I also have an 800 number that you can call anywhere in the U.S. and find the compounding pharmacy nearest you, because you're not going to be able to call Minnesota and get the medication usually. But did I answer your question? I place it with just a regular syringe. But the important thing is that the ciprofloxacin, the real medication, ciprofloxacin, comes in large granules. So you have to ask them to crush it with a mortar and pestle before they put it in a little capsule for you. And we'll show you that in a little bit. All right.
Any questions?
Any systemic antibiotics in addition?
Any other?
Are they taking antibiotics?
No, I'm not typically prescribing systemic antibiotics. Yeah.
If there is not a sinus tract, I know you just said most of the ones you've treated have had sinus tracts, but if they don't have sinus tracts, are you waiting for the periapical area to heal before you induce your clot?
In the cases that I haven't, I always take a radiograph beforehand, and if I get a sense that maybe something's healing, then that makes me feel better. But there are cases that I do 3 weeks and we're moving on. As long as I don't have purulence in the canal, I feel comfortable moving on.
Anybody wants to raise their hands and ask a question?
Could we get a PA taken here, please? Thank you. So let me back up real quick to IF2's initial radiograph, and I'm quite confident that we're going to see healing here. So that's the initial radiographs there. Let me address, as long as we're getting this, can you go ahead, Anita, and get that radiograph? Let me move forward to the question on the antibiotic paste. Excuse me. So here's what I get. Can you see that? Is that showing up there for you? I get it from a compounding pharmacy, and you can see the one on the left is the triple antibiotic paste. It's more of a yellow capsule. And the one on the right is the double antibiotic paste, the white capsule. And so we have them just one by one in volume and have them put them in I think it's an E-size capsule. You want a little bit, I would probably even go a little bigger than what I have, so you have enough to mix. We used to do, in the workshop, the 3-mix MP, which is the Hoshino protocol, where we're actually using his carrier, but my sense is that carrier is not needed, and it has essentially has antifreeze in it, right? So it's probably not a good thing to put in the tooth. We just mix it with sterile saline.
We want you to talk about the CT scan. Yeah. You can put in that image in there.
Okay, yeah, it's okay.
You need to move it back and forth.
Yeah. Yes, sir. Anesthetic solution? It's sterile, right? It's sterile. I don't see why it would be a problem. Perhaps using something like carbocaine without epinephrine might be, let me think about that. I don't think that really should matter. You could use any anesthetic. Okay, we're gonna just, I did give her just a little bit of bupivacaine before we started. We don't want to give too much epinephrine, especially in the cases where we're going to be stimulating bleeding up to the cervical level. And so we're going to go ahead with the carbocaine here.
Question?
Yep.
Just when it's convenient, could you just review the 3 antibiotics versus the 2, kind of the components? You have ciprofloxacin you mentioned, but just review the others when it's a convenient time.
Sure, you bet. So the triple antibiotic paste, according to Hoshino, is minocycline, ciprofloxacin, and metronidazole. And he has a very specific way that he's mixing it up, but he's crushing pills, and he's mixing in filler. And the thought is to get the pure drug. Okay, let's go ahead. Mirror. Thanks. I suppose I should probably be wearing my glasses here. I'm giving infraorbital here. And then we'll. Thank you, F2. Great. And I'm going to give a carpule on either side, and then a half carpule at the apices of both 8 and 9. Okay, a little rinse there. This is cool, man. This is like the ultimate board exam, right? $800 board examiners. Give me one more carpule. Okay, and then turn towards me just a little bit. There you go.
Dr. Geisler, we have a quick question here for you.
Okay.
How would you decide whether to use the triple or the double antibiotic?
Great question. So typically, I'm going to be using the triple antibiotic paste every chance that I get. However, anything in the anterior or a patient that is really concerned with anesthetics, I just don't want to risk it. To be quite honest with you, I tried a resin once, and it really didn't seem to work for me to prevent staining. So we just eliminate the double antibiotic paste. I haven't had a sinus tract not go away just with the double. I have my friend Bill Nudera did a case, and he didn't get the sinus tract to go away. He actually sampled through the canal, biopsied the tissue, came back as a cyst, and then he surgerized it and did a regenerative procedure. I can't wait to see his recalls. So that's kind of exciting stuff. But for me, the sinus tracts that have been there, they've all gone away.
It's important to keep in mind too that if you want to keep the same spectrum of antibiotics, you can use cefaclor instead of minocycline as reported by Dr. Trope and Thibodeau. So that's one option also, is to substitute the antibiotics. Just keep in mind that cefaclor, it's being a cephalosporin, may have 20% cross-reactivity for your patients that are penicillin allergic. So you have always to keep that in mind, okay?
Thank you, Anibal. Okay, guys. Let's go over there. So we're going to go right down the procedure here, and I think you can see there is that we use any anesthetic on the first one. For us, we're using no epi because we're going to be going on to the second appointment. Can I have some light? Is it an overhead light or no? Bring the scope in. piece of floss there, please. Piece of floss. Thank you. Great. Okay, yeah, I'll take the spoon. I think I will use a bigger, let's go with a bigger mirror. I like to use this zero mirror from Miltex when I'm under the scope, but I think when you're,
This is the
when you're
exit
working,
front of you.
when you're working on the anterior
Can
teeth, we
I
can
talk
really
and then you just
use a
move
much
around?
larger mirror.
While Dr. Geisler is performing the access, we're going to have Dr. Teixeira comment on the scan that you see on your screens up there.
I'm sorry, I have to apologize. My voice is dying, but we just took the CT and you can appreciate number 8 and 9, they are wide open. We know that from these procedures, from the literature, you gotta have at least 1 millimeter of wide open apex to be successful. And the patient has exactly what we need. That's kind of a basic type of case. And you can see in the frontal view, can you just put the frontal? And you can appreciate how open those apices are. And we have also the 3D. The 3D image is not showing much, but you can see there. Yeah, can you just enlarge the 3D, please? But the 3D. Let's see if we can see. You're gonna see that these apices, they are not flat. They look like they have been resorbed. And if you move around the 3D, you'll be able to see that. You see kind of a bevel, but we have a perfect situation for Regendo because these apices are wide open. And that's what we have. If someone has a question about the 3D or the cone beam, we can talk a little bit further about that. Can you put back the frontal view? Thank you.
Okay, folks, you might notice here that this doesn't look like your average cavit. I did a little bit of a sandwich technique just to kind of prevent washout of cavit. So it's cavit with a little Fuji 2LC over the top of it. I'm hoping that you're able to see what I'm seeing here. Yeah, you might notice that there's something blue in there. I stole this trick from Ove Peters, and I'm not sure who he stole it from or if he kind of came up with that. But sterile sponge, right? So we don't get wicking from cotton fibers. Endo Explorer. Okay, let's go with the Munspurs. Hey, I want to know, does anybody use the Munspurs? I love these things, man. I don't have any financial interest in them, but Dr. Muntz really created a great burr here. I don't know, I'm not really getting full speed on this thing. We're good with the air. We'll go with sodium. Okay. So some people might want to do a chlorhexidine scrub, you know, after they put their rubber dam on. I don't typically do that. But we're not using chlorhexidine in the tooth. And I'm basing that on Ernesto Trevino's work from San Antonio that showed that it was cytotoxic to stem cells. And so we use, on this first appointment, I would typically use a full-strength bleach and EDTA and then saline to disinfect this as best we can. Second appointment is different, though. We, based on Ernesto's work and Dr. Eliezer's group, showed that full-strength sodium hypochlorite or higher strength sodium hypochlorite actually is cytotoxic to stem cells. And so we're just going to be irrigating out the the double antibiotic paste that we placed here. I'm going to have to fill it quite so once you just take some of this out of here so my thumb isn't so far back. Okay. So we kind of have an estimated working length. Actually, we know that the Morita, the cone beams, are isotropic, and the measurements are accurate. Could I get a nice measurement from the technician back there of 8 and 9, from incisal tip to apex? Okay, EDTA. Get the sterile saline.
Got 19 millimeters on number 9, and approximately 19 on number 8. It does as well, 18.8.
Okay.
Working length, from the incisal edge to apex.
Where's our measuring? Do we have a measuring device? 19. Okay. So this maxi probe, you can get things to go a millimeter beyond it, right? So we'll set it for just approximately 18 millimeters. This is now saline. I'm just flushing it as best we can. No instrumentation here, just flushing. Volume's probably important. Okay. Okay, now we'll show you how we would place the, we're just going to mock this. We'll show you how we would mix the double antibiotic paste and place it in the tooth. And so Sheila is over here. She's opened a capsule. Let me show you this capsule real quick. There, Travis. Can you see that? About that size. Just a capsule. A pharmacist can do that for you. We just split it open. Mix it with sterile saline. Put it in maybe a 3 ml syringe with a tip. You can do various tips like capillary tip from Ultradent or a Vista tip, bendable tips, just something that's going to fit in the tooth.
I was asking what is the strength of the antibiotics. This is a pure grade, USP grade. You should ask a pharmacist to make a USP grade drug, which is pure drug. So what you're going to do is mix them 1-to-1 ratio with sterile saline. Also, I was asked, Dr. Geisler, what was the irrigating solution you're using? And I would just like to clarify, this is the second visit. So Dr. Geisler is actually just flushing the antibiotic paste out of there with sterile saline.
Right. So I'm kind of mocking the first one because I don't want to use full strength bleach because I'm going to be doing the second appointment, right now. But on the first appointment, I would use full strength bleach. I don't have any hesitation. We're not trying to get the stem cells to come in at that appointment. Our goal in appointment 1 is to disinfect as the best that we can. Yeah. That's good. So can you all see this? I really love the y'all. It's coming back. So we're going to just place this in one tooth. It's fairly liquid, and I just syringe it in. Now you could use a lentulo. One thing I like to do is take a sterile paper point, and I'll just kind of pack down in there, wick up a little extra moisture. And that's it. And then I'm going to take a sterile sponge, Jordco sponge, getting this a little bit more below the CEJ level. And then we'll fake it. I'll show you. So here's the Jordco sponge, and we're just going to place that, pack that down. And then, can you all see that? Okay. And then I'm going to be putting my cavit in. Patient's pretty reliable coming back. Then I can just do cavit, otherwise I'll put Fuji over the top. Okay. And that's where we go. The patient comes back typically 3 weeks later. Let's irrigate that out again. Yeah. This section. Okay, so
There's several ways of doing it eventually. You can use center seams. I like centers because they don't clog. I like that. Absolutely.
Okay.
3 weeks in between visits, usually, until signs and symptoms resolve. Dr. Geisler, we have a very good question
Okay.
here. The shelf life on the antibiotics.
My pharmacist tells me that when they mix them together, they have a shelf life of 1 year. Now, that's from her.
Yeah, seeing in San Antonio, we were encouraged to replenish our supplies every 6 months. So we just keep them on the shelf for 6 months.
Okay, so now let's fast forward in time 3 weeks down the road. And we're going to perform the phlebotomy here. So I was a phlebotomist when I went through dental school, and so I'm very comfortable doing this. Phlebotomy can be a bit scary for some people, and but it's really an easy skill. I mean, we're sticking people with needles all the time, right? So hitting a vein isn't so bad, but you know, watch, I'll miss the stick here. I don't know. So we've got a kit here, and the reason this kit was designed was just to make it easy for my workshop. It just has venipuncture supplies. We're not claiming that it does anything, but it's a nice little convenient pack. You don't have to buy things in bulk. A lot of times, if you're buying this tube, you got to buy 100 of them. So it's just nice to put it all together. And so, guys, I need this to come over. Oh, you've got it. Okay. Okay. Thank you. So I put a tourniquet on if2 here. I'm going to bring this over here so that you can just kind of set your arm there. Great. Get the patient's arm straight. That's really important, right? We take the tourniquet left over right, and we're just going to tuck with our middle finger. That's not very tight. You want it fairly tight. When I first put the tourniquet on if2, because I was just checking her out, I put it on the other arm and no vessels. So where we want to aim for is the antecubital area. And there's a few different vessels that we'll talk about that you want to go, but the median cubital vessel is where we typically go. But we're going to go to an accessory on the outside because it's just better for her. And so straight arm, tourniquet, we're going to palpate here before we clean. You can do two things. You don't have to use this iodine. This is iodine. You don't have to use it. I like to use it mostly for a reference. I'm going to line my body up to that vessel. I'm not going to be doing this and trying to stick this way. I'm lining up. I'm going to draw a line right here on her arm. That's the direction of that vessel. I'm going to want it to go in about right here. or so. And that just serves as a reference point for me. Most phlebotomists don't do this, but I like it because I can see where I'm going. Right? Just a simple needle butterfly. We're going to attach a tube holder to it. This is a tube holder. And all we need to get is just two tubules of it. Now we're going to anchor the vessel. Anchor with your thumb. That's really important to prevent the vein from rolling. And then we're going to advance at a 15 to 30 degree angle. You don't want to go too slow. You don't have to go too fast, but my glasses are fogging up. And there, I don't know if you can get in here, guys, and see here, we got a flash in this. We'll take a little piece of tape. I usually don't like to go over the butterfly, but I just want it to be fairly stable. And then the blood flow is very easy. Right? We're going to fill this up. This will kind of automatically fill to the level that we want it, about 4.5 mils. We're collecting it in sodium citrate, which is a reversible anticoagulant. This procedure is kind of really closely resembles Dr. Nitua's work from Spain, where we're adding calcium chloride back to the blood, to the plasma after it's spun down to coagulate the plasma. So if you notice, my assistant Sheila is inverting the tube. We want to do that 5 to 7 times to ensure mixing of the anticoagulant with the.
I would appreciate that. If you could ask that at the end. That question. Yeah.
Right. With the blood. And very simply, you can drop that whole assembly into the thing. I guess I didn't give her the phlebotomy grip, but it's nice to have a grip. You don't want them to pump it, but it's something nice to hold on to. And another thing that I didn't do, and you can do this right away, is to pull that tourniquet. In fact, you want to do that before you pull the needle. So my mistake there. But you doing okay, too? Okay, great. So now we'll come over here. Very simply, this is a great little unit, very inexpensive compared to like the $16,000 centrifuges that are out there. We just place our tubes in here. I don't know if you can see from there. Place our tubes in here. Simply close it. Turn it to the dial. It's spinning at 500 G for 10 minutes. Yes. Okay.
Dr. Geisler, I had a question here. Someone asked why not use negative pressure during your irrigation and aspiration of the contents of the root canal, meaning the paste they used. Would you consider using negative pressure aspiration?
Considering using negative pressure aspiration. I guess I'm not.
Endovac.
Endovac, sure. I think Endovac is a great tool. I haven't used it yet, but I think it would be a great tool. Be a great tool because you're pulling your irrigant, you're pulling the irrigant from bottom to top, right? I think it would be a great tool. I haven't used it yet, so. Okay, so I kind of got behind on myself here, but here's some consent language that I have. And a little bit of, you can go ahead and throw that right into your consent. I've got the images of the anatomy here. The one that we're going for is number 4, median cubital vein, but you can use the median cephalic and the accessory cephalic. We use the accessory cephalic for her. You want to avoid the one in red. That's the basilic vein. You're more likely to have nerve damage or get into an artery. If you want to know a little bit more, you can go to regendo.com. We set that up for the workshop attendees so they could look at the videos. The videos are something like this.
Basic venipuncture.
And I won't go through that. You can look at that online. So now, I wanted to demonstrate in a little bit, we'll demonstrate a needleless injection system. Not quite yet, so we're going to move on to the rest of the second appointment here.
Todd, this is a good question here. How long is the fiber matrix good for? Meaning, could someone go to a phlebotomist, do this procedure, and bring a tube to the office with that?
You can. Plasma is shipped all over the world. You wouldn't want to add the coagulant to it right away, so you'd want them to collect it in sodium citrate, bring the plasma to your office, and then add the calcium chloride right before you use it in the procedure.
Thank you.
Okay, so now we've irrigated. Just as a reminder, we're irrigating with a lower concentration of sodium hypochlorite, EDTA, sodium hypochlorite. Now I'm going to go ahead and do a 10-minute soak of EDTA. And the logic behind that is we know from Anthony Smith's work that EDTA will release growth factors from the dentin, such as TGF-beta. And 10 minutes is a bit arbitrary, but since we have a 10-minute spin on the centrifuge, that seems to be a smart thing to do. Seems like a logical period of time. Okay, and so we'll do this. Now, one of the things that I hear most of from practitioners is that they don't want to stick a kid. And the reality is most of these guys are kids, right? They're 8, 9 years old. I'm going to get a volunteer to show something that Biomatrix has here. It's a needleless injection system. And Children's Hospital in Dallas uses it. It has a little CO2 cartridge at the top. And there's no needle. This is great for kids. They use this on kids that have to get IVs all the time. And so what we're going to simply do is you can use buffered lidocaine with it if you'd like, but I just use carbocaine. So I'll just take carbocaine from here, very simply take a bit of carbocaine from a carpule. All you need is 0.10 mils, 0.10 mils, 1/10 of a mil. So you take the syringe off, get rid of the excess liquid, and then we're going to just connect this very simply there, and then we're going to add I gave you a little bit too much there, but I don't think you'll cry. So simple safety trigger, pull it down. You've got your little gun. You're going to look at the vessel here, and we're not going to put it directly over the vessel, but close. And just warn the kid it's going to sound like a pop can or opening a can of tennis balls. So I'm going to go here, and then notice that, and then we're going to just pull to the side, just light pressure. It's kind of loud. That's it. So can you get a close-up on that? Right there? So he's got a bit of a wheel and a little bleeding point. Not a big deal. It's right adjacent to the vessel. And now this area is numb. About an inch or so there. And so that's a way to break down some barriers. If you're not really excited about doing venipuncture on children, it's a great way to do it. They do it at Children's Hospital. So thank you. Let's give him a round of applause. Okay, so we're almost there, I think. Yes, sir. Right. I could have. I didn't warn her about it, so she'd never experienced. I could have. There's no reason why I couldn't have.
Got a question here, Todd?
Okay. Yeah. The reality is truly that venipuncture does not really hurt. I don't know, people have gotten their blood drawn, it's not that big a deal, right? But it's just a way, it's a way to help kids deal with it, I think. And I think if they feel nothing, then the clinician's a little more comfortable too, especially if you're not used to doing phlebotomy. Okay.
I got a question yet one more time on the irrigation. I think the slide says 0.6% sodium hypochlorite. Is that right?
Yeah, just a Dakin solution basically is what I'm thinking. And that's arbitrary too.
So that's what you use to remove the paste, or you use sterile saline?
I use sodium hypochlorite, EDTA, sodium hypochlorite, EDTA, sterile saline.
Okay.
Okay. Now we're going to do the traditional Banks and Trope on tooth number 8. So we'll dry with some sterile paper points, and we'll stimulate bleeding. We'll place MTA, and then Fuji and composite. Looks like I have a little bit of paste in there. Yeah, let's have the saline back. Perhaps even maybe ultrasonic in a situation like this would be helpful, as long as it's a small instrument and you're not touching the walls, just to help you irrigate out. Okay, let's have the sterile paper points. So one of the things that we're doing is, of course, we're stimulating bleeding, but a lot of times, based on Joe Petrino's work and paper in the Minnesota group, talking about challenges of regenerative endodontics, and one of the biggest challenges is to get it, found to get this to bleed into the cervical level, and so avoiding epinephrine is important. But now let's go with the 15 file. So I can already see, can you appreciate that there's some bleeding in the canal already? So sterile, 15 file, long. One trick that I heard came from Martin Trope was to stick this into EDTA. Of course, EDTA is an anticoagulant. And stimulate the bleeding here. Another thing to do would be to bend your instrument just a little bit. I thought there might be another instrument that might really work well, as long as we're talking about other things. And Ebel, you might have to help me with the name of it. I forgot now. The night tie that comes out and whips around. Remember the name of that? Anybody? Apexum, that's right.
Todd, can you discuss some of the things that we can do to ensure that we can achieve bleeding from the tooth? Can you comment on that? Like not using epinephrine?
Not using epinephrine.
What did you use? You used a curved file, and you went through the apex to do that?
Curve file through the apex, and I think I'm going to need to use a little bit of EDTA here. Can we get a little EDTA in there? Take this off. So I may have made a boo-boo just in giving her a little bit of bupivacaine before we started, so there was a little bit of epinephrine in there. Probably not a smart idea. Probably should have just stuck with the carbocaine, because I'm getting some bleeding here. But one of the biggest challenges is just getting it all the way up to the cervical level. Dr. Hargreaves was talking about in his lecture, I hope you all got a chance to see it, his lecture. He had a lot of the hard science there we're not going to have time for, but he did talk about outcomes seem to be good even if you can't get this up to the cervical level. So we'll get it as close to the cervical level as we can. We'll be placing collar tape and then MTA. There we go. Now I'm seeing it. The nice thing about the collar tape is that you don't have to wait to place your MTA. Dr. Torbinajad, I think, might have a bit of an argument with that in that since MTA is bioinductive, that you really would like to have the MTA sitting right on top of blood clot. Hard to say that's necessary or not. Okay, so there's our blood clot. We're going to take some collar tape here and place over the top of it. I like to cut it in little strips. Some people like Scott McClanahan, he likes to use, and the Minnesota group. Can you grab him at the tip? Grab him at the tip. They like to use collar plug. And right about now, I think I'd like to use collar plug too. Can you get it? Okay. There we go. Much better. Okay. So I'm just folding it in there. So I want this fairly high up in the tooth. And because a crucial area to get thickening of the root would be the cervical region. Speck noted in 92 that it's the cervical region where a lot of teeth will break for long-term calcium hydroxide. And so that's, and partially because of the buttress of bone in the area. They're going to break right at the cervical level. Okay, so I've got my, let's go with the sterile cotton point. So what I'll usually do, depending on, a lot of times we'll see this collar tape fill with blood, but we've got a little more in there, but I'll take a sterile paper point. Thank you. And we'll just tamp that down. Good. And wick up any extra bleeding. Okay, great. Now we're going to go on to the MTA placement. And so here's one of the dilemmas that we found is that based on Dusty Watts and Dennis Holt's work out of Wilford Hall, they saw that even white MTA stains. So you can go ahead and put white MTA in there, but I can say from personal experience, it still stains. We'll put white MTA in here, and but we'll modify the technique on the other tooth, where we're actually not even putting MTA in there. Yeah.
Just have a quick question.
Sure.
What quantity of calcium chloride do you place when you're trying to achieve the coagulation?
Yeah, so based on Anitua's work from Spain, they like the final concentration of 22.8 millimoles. And so when you're using 4.5, which will end up with about 4.5 mils, if you add a half a mil of 0.228 molar calcium chloride, then your final concentration is 22.8 millimoles. Okay, guys, while we're waiting for that, you can go ahead and keep mixing there. I think this is done, and so we're going to, it's not done.
Todd, I got an interesting question here. Let's say you have a tooth that it's immature, open apex, but has irreversible pulpitis. Would you perform a regenerative procedure, or would you modify that treatment such that you somewhat getting rid of the inflamed pulp, or would you try to do a modified pulp, a vital pulp therapy in that case? It's an interesting question.
So I'm understanding the question to be, you've irreversible pulpitis, you've gotten into the tooth, there's vital tissue there, obviously.
Right.
It's inflamed. My sense would be to do a cervical pulpotomy, spec pulpotomy in that situation. Try to keep the nerve alive.
Right.
Despite the fact that it has, that there's inflammation there, I would still do that.
Yeah, I think that's a great answer. I think that you're trying to recapitulate the tissue that was there, but the tissue being there, I think that a more conservative
As fast as we can.
a vital pulp therapy would be indicated in that case.
Thanks. Let's go with amalgam carrier. Let's go with amalgam carrier. So I like the MAP system, and that works well, but if we want to move along a little quicker, I like to use the amalgam carrier with the MTA. Thank you, guys. Okay. Again, I'll...
Dr. Geisler, I have a question here.
Yep.
On what measures
One
did
more.
you take to keep the color code or the color tape sterile from the packet to the patient?
Be very, very careful. I think you want to use, your sterile instruments. Try not to touch the outside of the tooth. That might be a good argument for disinfecting the external surface of the tooth with chlorhexidine. That's good. We're good there. Fuji. Okay, we're going to leave that like that, and then we'll move on to 9, and we'll do Fuji and Exposit later. Okay. So now let's move on here to tooth number 9. You didn't have the inserts in there. I can't grab these out without turning this over.
MTA set.
Hold that.
And then place the restoration. Place it temporary, go back, save it, MTA set.
You're going to need another one of those. You're going to need another syringe. So what we're talking about is we left out the insert in this centrifuge because I should be able to just grab this out of there. But what I don't want to do is turn this upside down because then I've mixed our plasma. So can you see that from over there, guys? So this is what it looks like. Right? Most of the platelet-rich fraction is kind of on the bottom layer, so we'll discard kind of the top half layer into a discard tube. Where was that syringe? Did you just open that? Okay. So can you get me a new one? Give me a new one. I'll open it. Thank you. So one way you can do this is you can just Go in here, we'll take the top fraction off. And then we'll discard it in our discard tube. Same thing with this side. Now, another way to do this would be to go ahead and take the tops off, and that's probably just as well. It's easier. Great. Yep, so we're at about 4.5 mils there. And now we're going to add 0.5 mils of calcium chloride, 0.22228. I ordered this from my compounding pharmacy as well.
Todd, can you take a step back and let's kind of just recapitulate what we just did? We got the tube that spun on that centrifuge for 10 minutes.
So we spin for 10 minutes at 500 G. We take these out, being careful not to mix these, because you'll mix up the red blood cells with the plasma, and then you won't have it separated anymore. So be careful with that. And then we've taken the top fraction away. Oh yeah, right here. We've taken the top fraction away and discarded it, and then we keep the bottom fraction that has more of the concentrated platelets. Now what we'll do here is we'll take a little bit of this calcium chloride. We only need a ½ mil. And we're going to add it back into our plasma. And that's it. And then we'll invert it here. This will take 20 minutes to clot. And so the nice thing about using Colotape with this is that you don't have to wait. You don't have to wait till it clots. So we place this in the tooth. If we sat here and held this for 20 minutes, this would be a gel, and you could turn this upside down without it moving. But we're going to just go ahead and inject that into the tooth. You only need about, you don't need very much to place in the tooth. And then I need a paper point, sterile paper point. Okay. Now, importantly, in these cases, I'm still going to stimulate bleeding, but it doesn't matter that I get the bleeding up to the cervical level in these cases. In fact, Torabinijad and Terman didn't stimulate bleeding in their case, and they hypothesized that it was the growth factors in the PRP that actually induced the tissue to come into the tooth, and that kind of makes sense to me. But based on Anibel's work and Tyler Lovelace's work in San Antonio, it is evident that just by stimulating bleeding, we get progenitor cells to enter the tooth. They did RT-PCR to analyze that. Very important step, I think, and I wouldn't leave that out. So we'll take 15 or 8 file. we didn't bring a ring, did we? Okay. So now we're going to go ahead and inject this back into the tooth here. I'm going to fill it all the way up to the cavo surface margin. And then we're going to go ahead and place the collet tape and again condense with a sterile paper point. Collet tape. Touch the end. Don't touch the end. Yeah. Can I have another one, please? Another one, please. Here, let me grab it. Okay, condenser. There we go.
So Todd, right now you're just trying to get the PRP below the CJ or at the CJ level? Is that what you're trying to accomplish?
What I'm doing is I bring the PRP all the way to the cavo surface margin because you can extravasate the liquid as you place the collet tape, and that's what I'm going to do now. I still want it at the same level. I want it as high as I can get it. I know that Ken talked about trying to even get dentin up into the crown of the tooth, into the pulpal chamber of the tooth. Sterile paper point, please. And MTA, or no MTA. Fuji 2LC, please. Nope. So here I'm just tamping on that. You can see that collet tape is wet. Just tamping on it. And so the idea here is to place basically an orifice barrier over Fuji 2LC. There's very minimal evidence, but the one paper that I look at is Selleck's paper to the sealing of glass ionomer. And I think this light is going to set me up here. So I'm putting Fuji on both of these. It's probably not that helpful. Does this scope have a safe light on it? I don't think so. Let's see. So I just want to cover over my MTA. It doesn't have to be a thick layer. And then we're going to go ahead and cure this. We'll bevel, etch, prime adhesive. Go ahead and cure on both of those. So do you see the difference? What I'm doing here is the one is the traditional Tropes and Bank. We're doing stimulation of bleeding to the cervical level, MTA, and then covering it with restorative materials. The second one was, tooth number 9, was stimulate bleeding, not necessarily to the cervical level, AFM, cervical level, collet tape, glass ionomer, and composite. So slightly different. I have a number of these cases with the glass ionomer only, and I'm hoping to publish some of these cases. Thank you. Okay. High speed, football, bevel. So someone, can you give me a time here? We got, what kind of time do we got? Anita, can you give me a time? It's what? Etch. Aníbal, can you tell me what the time is, just so that I'm aware of it?
It's 11:20.
11:20?
11:20.
Okay, great, perfect, perfect, perfect. Okay, let's rinse here. Dry real well. And air.
So I was asked by more than one person the rationale on the collar tape, collar plug, and that's a collagen one type of barrier that you just put there to give a little structure.
Bit of a matrix, yes.
Yeah, just to
Bit of
hold
a matrix.
MTA.
You don't need a lot of it, just enough to hold your MTA so your MTA is not going way down into the canal. And especially if you can't get, in the traditional method there, if you can't get the bleeding to the cervical level and you don't want to wait 10 minutes, 15 minutes for it to clot, you can go ahead right away. Okay, so we're going to put some composite in here, and we'll, if to, I'll polish these babies up here in a little bit. And we'll get the occlusion all right, but for the sake of time, we'll wrap up here the clinical portion. Yeah. Okay. Yeah. Go ahead and cure it.
Todd, I was asked a question. Not a question, but I want you to comment on the evidence on PRP as being useful, if at all,
Right.
in regenerative endodontics.
So in regenerative endodontics, there's not a lot of literature in that. There's the case report by Dr. Torbinajad, and Terman was the very first, really, case report. There's mixed, the jury's mixed, especially when it comes to bone regeneration on PRP. So there's many things that say PRP doesn't really do anything for bone regeneration. But I think it's fairly unanimous in the perio literature, at least my reading of it, is that PRP is helpful in soft tissue healing. And what are we growing in the tooth? It's soft tissue. So it made sense to me that this could be an improvement over blood clot. And based on the case report, we're seeing results in 5.5 months that would normally we be seeing in 30 months. So can I have you all do something for me? And that is to give my patient a round of applause. And my lovely assistants who probably could feel my stress there. So you guys are awesome. Thank you so much. So here are my top 10 suggestions based on my reading of the literature. Take what you want, discard the rest. First one is to consider this procedure for all immature roots, including, well, except the ones with caries exposure. Then we're going to do sphect pulpotomy. I would also include ones that are immature roots that have been previously treated. I have about 4 cases now that I've done this on previously treated teeth, and the results so far are looking good. I'm not getting as much root width as I would like to see, but we're getting definitely healing and apical closure. So if you got something wide open, you can grab that GP out of there, consider it. You can use chlorhexidine for external disinfection, but based on Trevino's work, I wouldn't use it inside the tooth. Certainly not at full strength. Number 3, based on Ernesto's work and work from Dr. Eliezer's group, dilute your sodium hypochlorite, especially on the second appointment. I think that's important. It's cytotoxic to stem cells. Number 4, use the 3 mix on molars or teeth with metal or PFMs, that type of thing. That makes a lot of sense to me. Otherwise, if it's really crucial, right up in the front, 8 and 9, 6, 7, 8 and 9, 10. Let's add 11 to that too. Use the double mix. And if you can't get the sinus tract to go away, then you go to the 3 mix. Avoid epinephrine on the second appointment. I made that mistake here, giving just a little bit, quarter carpule of bupivacaine on either side, and I think it affected whether or not I could get that blood clot up there. So I think that's important based on the Minnesota paper. And then use EDTA to soak, arbitrary 10 minutes, that's how long it takes to spin, so I would do that. Expose those growth factors in the dentin, TGF-beta, based on Anthony Smith's work. And then, based on Anibel's work, Tyler Lovelace and the group at San Antonio, stimulate bleeding to deliver the stem cells into the root canal space. Number 8, if the patient's needle phobic, consider the needleless injection system. That seems to be a work in Children's Hospital. It could work for your young kids that you have in your practice. Also use Colla-Tape or Colla-Plug as a matrix for your restorative material so you don't push the MTA way down there. And then use MTA on molars with metal or PFM crowns again. Otherwise, in the anterior where it's really crucial to aesthetics, I would consider what we did here, which was glass ionomer over the Colla-Tape and then bond composite. So just based on this, what you saw, are there any more takers on that volunteer thing? Would anybody be willing to go back to their practice and try the procedure? It doesn't have to be the AFM procedure, but who's maybe a little bit more comfortable doing the regenerative procedure? Anyone? Anyone? A few more hands. So that makes me feel good. So here's the question that I posed to you. Who are you? And it's a question that I posed when I was out in Washington, D.C., and it's who are you with regards to regenerative endodontics? Regarding my attitude towards endodontics, regenerative endodontics, I'm more of a Jack than a Morgan than a Jack, or you really just don't know what the hell I'm talking about, which is probably 90% of you. This is a great clip from Bucket List. I love this movie. Listen for Morgan's scream.
Always been afraid to go up in an airplane. Now I'm going to jump out of one at the whim of a maniac. 15 seconds. No, wait, I can't do this. Sure you can. No, I can't. Really? No. Let's hit the steel.
Geronimo! So are you Morgan or are you a Jack? But here's another important thing. We need to claim this regenerative as part of our specialty. We all know that endodontics was in jeopardy not too long ago, right? So part of claiming this is we add it to the definition of our specialty, and there's a special committee that was formed to do this. But we need to demonstrate a unique expertise in this area, so it's really important that we consider doing this. There's a coming evolution in endodontics. I really believe that. It may be soon. May not be that soon. Maybe we're way ahead here. But I do see a day when we're going to be placing scaffolds in teeth and not gutta percha, and we will truly be bringing dead teeth back to life. We are going to live up to the title of guardians of the pulp, right? Guardians of the pulp. Not only guardians of the pulp, but growers of the pulp. And if we know one thing about evolution, the overriding principle is that the species that is most adaptable to change survives. So I encourage you to embrace change and have a beginner's mind. And it's a credit to people like Fabricio and Anibal, Donna Matschek, Alan Law, Peter Murray, George Huang, Ken Hargraves, and many of you here in the audience that are approaching this, that are truly experts in the field and approaching it with a beginner's mind. So let's open ourselves up to the possibilities. Open ourselves up to the possibilities, because when we rethink, when we change the way we think, and we have a firm conviction to do something and to act, we can generate new and exciting outcomes. So rethink, resolve, regenerate. There's changes ahead. Are you a Morgan or are you a Jack? I say let's be Jacks. Geronimo, thank you very much. Appreciate it.
I would like to invite each one of you with questions to come to these microphones that are in each corner of the room. They're live. So just come to the microphone and one by one you can ask questions. And then we're going to have a little section.